Hello, my name is Philip George, and I wanted to thank the America's Hernia Society for the opportunity to present. My talk is entitled Minimally Invasive Abdominal Wall Reconstruction, Fad or Game Changer? Results of the largest series of minimally invasive retromuscular repair experience. I have no disclosures. Incisional hernias are one of the most common diagnoses a general surgeon sees in practice. When there are about 350,000 laparotomies performed in the United States annually, with an incisional hernia rate as high as 20%, this is becoming a more prevalent problem that we see in practice. With obesity rates as high as 42% in the United States, the treatment of hernia disease is becoming more complex. Traditionally, hernia repair involving component separation was a strictly open procedure. With the advent of newer, more advanced, and more minimally invasive techniques, component separation can now be performed through smaller incisions and can potentially avoid all of the sequelae of a large open incision. Both retrorectus dissection as well as transversus abdominis releases are now being performed more commonly with both the robotic platform and with laparoscopic instruments. Because of these minimally invasive techniques, we can now offer surgery to patients who were once told that their obesity was a contraindication. However, large studies have yet to be performed looking at outcomes on these minimally invasive abdominal wall reconstructions. The purpose of this study was to look at the operative statistics and perioperative outcomes of minimally invasive abdominal wall reconstructions at our institution. We retrospectively reviewed all patients who underwent robotic or laparoscopic retrorectus or Rives-Stoppa hernia repair or transversus abdominis release. We collected information from patients between August of 2015 and April of 2019. We separated the groups into laparoscopic and robotic repairs for analysis. Demographic data, operative statistics, and operative outcomes were analyzed. We evaluated operation statistics, which include operating time, defect size and size of mesh used, hospital charges, length of stay, and percentage of drains used and how long they were in place for. Outcomes we looked at were ileus, small bowel obstruction, surgical site infection, seroma, hematoma, thromboembolic events, respiratory and cardiac complications, as well as recurrences. These were the statistical tests that we used. In terms of demographics, we found some interesting trends. Our average BMI was 32.8 and was higher in the robotic group. Along with a higher percentage of patients with high ASA score and higher percentage of diabetics in the robotic group, this trend may indicate a predilection to using the robotic platform for more difficult cases. We also found that we tended to use the robotic platform more frequently in recurrent cases and cases with multiple defects. We also found that we performed significantly more Rives-Stoppa repairs in the laparoscopic group and more transversus abdominis releases in the robotic group. We found that the robotic approach took longer in the operating room, which may be due to docking, draping, and engaging with the robot, along with instrument changes. Defect sizes were larger in the robotic group. Interestingly enough, the mesh sizes were smaller in the robotic Rives-Stoppa group and larger in the robotic TAR group. Charges were higher in the robotic group, and overall the transversus abdominis releases were almost twice as expensive as the Rives-Stoppa repairs in terms of hospital costs. Patients undergoing TARs were more likely to have a drain placed, but both were generally in for the same amount of time. In terms of operative outcomes, there were no difference in complications between the robotic and laparoscopic groups. 30-day complications were similar between both groups. However, when we accounted for patients with a longer than 1 year follow-up, we found that the overall complications and SSI were higher in patients undergoing laparoscopic abdominal wall reconstruction. We also found that once we followed patients past a 1 year follow-up, we noticed 2 recurrences in the robotic group, which reinforces the importance of long-term follow-up. In conclusion, we analyzed our database of 535 patients undergoing MIS AWRs and found that laparoscopic MIS AWRs had slightly higher complications in patients with greater than 1 year follow-up. Otherwise, perioperative complications were similar between both groups. Patients with BMI greater than 34 included in analysis showed no increased risk of complications. However, future studies are needed to be performed to compare these groups further. Some limitations of our study is that it was a single institution study and that it was retrospective in nature. Again, thank you for your attention and to the America's Hernia Society for this opportunity to present.